Hi, I'm Amit Skandan. I'm one of the internal medicine hospitalists. I practice in Southeast Health Medical Center in Dothan, Alabama. I also wear a few other hats. I'm the core faculty in the internal medicine residency program, as well as the assistant professor at Alabama College of Osteopathic Medicine in Dothan, Alabama as well. In addition to that, I work as a lead physician advisor and the director for the CDI team at Southeast Health as well. Both Raman and me are happy to join you. We both serve on the editorial board for The Hospitalist, as well as have been serving on the annual meeting committee over the years. Raman.
Thanks for the introduction. Amit, I'm Raman Palabindala. I'm Associate Professor of Medicine in University of Mississippi Medical Center. I'm also Division Chief for the Hospital Medicine. I'm very active with the education, been attending every annual meeting ever since 2012, if I remember. I didn't miss any. I love being here, and we are here to talk about our experience of this annual conference. Amit, I noticed there's a lot of emphasis on quality innovation during this conference. So what's your thoughts on, what is your big picture?
I'm glad you brought that up, Raman. I attended a bunch of quality tracks actually, and I was really impressed by what was going on at HM19. One of the talks which I attended, which was really inspiring, was the updates in quality and patient safety. This was done by Dr. Harry Cho and Dr. Christine Song. They reviewed the recent literature which was on high impact in quality improvement projects. And there was an article which talked about, they had discussed about unnecessary testing. It was very impressive.
Which we do that all the time.
Exactly. They even had an example in the same article where they talked about a young patient getting an unnecessary colonoscopy and ending up with a diagnosis of high-grade lymphoma, followed by multiple invasive testings, only to be told that that pathological diagnosis initially was benign. So there are a lot of domains of negative outcomes related to unnecessary testing. It's not just physical, which is about 70%, believe it or not, and
wow.
Emotional, financial, treatment burden, as well as the patients having a dissatisfaction towards healthcare. Is there anything you had
Wow,
liked?
I am impressed. So, I mean, you always think about like, oh yeah, it's an emotional stress, but I'm surprised to learn that unnecessary testing is actually physically harmful in 70% of the cases. That is just very, so I think the message out to our colleagues is not to do any testing unless you're very sure that you're going to use it.
I agree.
All right, that's great.
It basically opens up a box which you may not be able to close as easily while causing more harm to our patients.
That brings up a discussion about the high value care, I guess.
Yes, it does. Yes, it does. You know, when we talk high value care, any of the programs we have been to, we have worked together as well. Anytime we talk high value care, people talk about EHR, let's use EHR to improve high value care, right? And
Yes.
most of the time, the moment you bring up EHR, they talk about let's add the cost of the drug or cost of the lab, and that would change the culture, change the choices, right? So Dr. Harry Chow actually did a literature review regarding this, and do you know what the finding was?
I guess it was successful.
It wasn't.
Oh.
It wasn't.
Really?
It wasn't. And
so I mean, if I'm looking at an MRI costing 3,000, I would probably will back off, right?
You probably would. In certain instances, it might help, but it also, when you see a cost being lower, you probably don't care about that test. You think it's only $5, and it doesn't
I didn't
make
think
much,
about it.
and that adds up. And that
So
adds
putting the numbers right next to the labs and images doesn't work.
may not help.
So it is changing the culture.
It is. I
Okay.
agree.
All right. That's good to know. So there is an evidence behind,
Exactly.
not like it's not going to work if you just add a number tags to the labs.
I agree. But I'll tell you, EHR does help, the pop-ups do help with telemetry discontinuation. We did have literature search on that, and I was really intrigued by that because I've seen some smaller projects earlier in my own personal experience which had not helped. But this literature shows that pop-ups do indeed help stopping the telemetry usage.
So most of the organizations were leading towards the nursing protocols in telemetry discontinuation. So the literature suggesting alerts on EHR might help.
Might help.
Excellent. Oh, that's good to know. All right.
And Dr. Song had done a literature review, and actually this was 3 articles. She talked about the effects of inpatient hospitalization on sleep. And
Yeah.
this, you know that you stay in the hospital, you're not getting good sleep, but I did not realize how much the effect of this was. And the way she reviewed the literature made me very concerned, because she said the outcomes, which are really bad, are very similar to PTSD patients.
Oh my God.
Exactly.
Not having sleep is equal to PTSD?
It's almost the outcomes, long-term outcomes are equal
Ooh.
to PTSD.
Oh.
But there are means you can help the patient.
I wish I will know the solutions. What is that?
So she did do further literature search on recent articles related to the sleep deprivation and its effects. There are two means you could use. One is EHR default changes to avoid unnecessary EHR moves.
Okay.
And the second thing is nursing empowerment and education. And she brought up a very important point. The study she had quoted also looked to see if you take away nursing empowerment and education, does EHR alone make a difference? And it doesn't.
Oh,
So
interesting.
you
So
have to have
you
both.
can make any changes you want in the electronic health records.
Exactly.
If the nursing staff is not on board, then
Exactly.
it's not going to work. So
Exactly.
to make the patients rest better,
You need
nurse
their
is your
support.
partner.
Exactly.
Excellent. That's
Exactly.
great. That's great. That's good to know.
Exactly.
All right.
And what do you think about her thoughts about the team-based coordinated care? I was really intrigued by this, but I wanted to see what you thought about that.
So multidisciplinary team rounds, I think most of the hospitalist teams kind of mastered it. I mean, it's a matter of how you're incorporating all these team members into the bedside roundings and then multidisciplinary team. I mean, several studies there out there, and then some of the literature reviews proved that it is actually cutting down on the length of stays with early discharges and also helping the 30-day readmissions. Yeah, it is, it's been discussed multiple times, but again, one more thing to our colleagues is make sure that you are doing a team rounds. That is a definite direct impact on readmissions and length of stays,
One of the interesting studies Dr. Song had brought up was a study where they used a comprehensive pharmacist, added that to the discharge team, and that actually reduced their 30-day readmission rate.
Oh.
And it was interesting that the study also incorporated the cost, and adding another additional pharmacist did not impact the overall cost. Which makes it intriguing, because other organizations should probably consider.
So there you go, return of investment. Make sure that you have appropriate discharge medication reconciliation. You can save money on readmissions.
Exactly,
Well,
I agree.
Well, teamwork is the dream work. Who doesn't agree with that?
I agree.
All right. So I want to actually bring the discussion about Dr. Miller's from Lee Valley. I thought his comments and then the summary is really impressive.
It was. The way he approached quality was quite different and interesting. He used the claims data and the cost data on individual patients as well as groups of patients into their clinical outcomes. So it basically, what he was trying to lean towards is you are taking more and more responsibility of their financial outcomes as well, which was very interesting. This is something that he does as a physician advisor in Lehigh Valley.
That reminds his slides, and he was actually trying to do the cost analysis affiliated to the DRGs.
Exactly.
And then trying to give the individual providers the feedback.
Yes, he did.
And claims data, not just, so it's actually how much money you gain on this, and then based on the DRGs. I thought that's an interesting approach.
Exactly. You know, Raman, yesterday there was a talk on care of medically complex patients. This was done by Dr. Sumita Rajan, and you seemed extremely impressed. You haven't stopped talking about it. Do you mind sharing what exactly was going on that made you so interested?
Just like the complex patient care, the talk was really complex, and the way that Dr. Rajan escalated the talk based on giving all the history about how we come up with the case mix index and then complexity, severity of index, and several things that are related to how we define our sick patients. There was an interesting comment. When you're working in a tertiary care center, 15 patients will feel like 50. I feel that every time working in university settings. But one must think, and then one very interesting part that I learned from her talk is, you have to approach the complex care patients looking at a big picture where you're focusing on post-care transitions,
Exactly.
where you're teaming up with the partners outside the hospital.
Exactly.
And this is basically trying to find a gap between inpatient care and outpatient care. And that
Exactly.
goes to the more emphasis in recent times about the population health. I think Dr. Rajan summarized. I think this is one talk where you probably want to go back and then review the slides to learn as much as you can.
I agree.
But I think she did an amazing job.
And she brought up, and I'm surprised I had not used this in my clinical practice. She brought up a frail scale.
Frail scale, yes,
I was so
exactly.
impressed.
That was really, the fragility, whether the patients can ambulate, the functional capacity of this sick patient population is a very good index that we really try to we are not actually focusing on. And I think that I'm going to go back and then actually make as a smart phrase.
I agree.
And I'm going to put that in
I agree.
every progress note.
I agree. I'm going to treat my residents the same and use it on each individual patient, especially geriatric patient. I'm surprised more hospitalists don't use the frail scale as much. It should help you with your disposition. So, yesterday we were judges on the quality innovation track for the poster competition as well. I was really impressed by some of the posters which were present, some of the ideas which were present out there. I was trying to see what you thought of some of the posters which you might have judged.
So I was in the wild card judging category,
Okay.
and this is basically you go around and then try to find interesting posters. Guess what? The winner of the wild card is actually it's not even a medical student. He's actually trying to get into medical school
wow.
and working in Harvard. This young student did a phenomenal job in analyzing the data. So they were basically using artificial intelligence, integrating patient experience questionnaire with the rounding patterns. I mean, it was amazing. And they're actually going to publish this data.
Interesting.
But they are going above and beyond using the technology to improve the patient experience and also integrating the same AI and predictive analytics to alert the physicians, at the same time patients, and actively taking feedback from the patients and family while they are in the hospital.
Wow.
And also teaming up with the nursing staff. It was just an amazing, and they're using technology to a maximum extent.
Wow.
And I thought
I'm
that was
impressed.
one of the best posters that I recently saw.
Wow.
And as we all know, that healthcare is something that we adapt the technology very late.
Uh-huh.
You
I
probably
understand.
saw my hashtags like, EHR is stupid. But this is where we need to learn from this new generation how you actually take this amazing technology
agree.
and then use it towards patient experience and
Exactly.
patient safety.
Exactly.
I thought that was a really impressive poster.
I agree.
What about you?
Speaking in the same lines, there was a poster from the Medical College of Wisconsin, Vanessa McFadden. She's a pediatric hospitalist, I believe, and she had used for her adolescent population using Snapchat as a means to educate them regarding reproductive health, which was an amazing idea, which I thought was very innovative. She also showed us data regarding the usage and how many times you clicked on it and versus you just giving pamphlets to the patient. But I think to understand the patient population, what means works best for them is truly impressive. The winning poster, however, was Dr. Gujral from Team Health. She did an interesting study. She's a tele-hospitalist, and she did an interesting study regarding tele-hospitalist usage to help the hospitalist team as well as the ER throughput. She took it a step further and looked at what the patient perceptions were regarding the care as well as patient satisfaction. And in some metrics, to be honest, they were actually better. I was really impressed by her presentation as well.
That reminds me about another poster. This was primary emphasis on PFAC, which
wow.
is Patient and Family Advisory Council. So I think this is getting a lot of traction recent days, that every organization is trying to have their PFACs, where you're inviting the family of the patients, and then some of the patients are strongly advocating and trying to identify the problems in the hospital and give feedback to administration where you are changing the patient care.
Interesting.
And we do have in University of Mississippi, but this one was actually trying to have PFACs for every division.
So you're saying to use patient as a data center basically to get feedback.
Yeah.
I think in healthcare we don't use it as much, and most of the other industries use the clients as the main source. We use it mainly for patient satisfaction, but I completely agree. That seems like an interesting study.